Welcome to the Work to Live podcast. I'm Mike DiNatale. This week's episode, I sit down with my good friend Ali Etman, who is a third-year family medicine resident at Banner University Medical Center in Phoenix, Arizona. In this conversation, Ali peels back the curtain on the grind of pursuing medicine. He shares whether or not he thinks the sacrifices he's made in pursuit of medicine are worth it. And he also gets into what his long-term future plans are with combining his career as being a doctor with his passion of cutting hair. If you enjoyed this episode, please like this video and subscribe to the channel. That's the best way you could support. Without further ado, here is Dr. Ali Etman. Ali, my friend.
How are you?
I'm good. How are you, man?
Doing excellent, man. Good to see you. It's been a minute.
It's been too long, honestly. Thank you for joining me here on the podcast. I want to start first by congratulating you entering your final 2 months of your residency.
Thank you. It feels good. There's a light at the end of the tunnel, so I'm really excited.
Just to start and to provide a little context for people who might not be familiar, and also to set the stage a little bit for the conversation, can you give us a bit of a summary for people who might not know of the process of going to medical school?
The majority of med school applicants major in some sort of science, and then when they do their test and then they get into med school. Med school is becoming increasingly more competitive. The average age of matriculation now is about 26 years old. So a lot of students are taking gap years, 1 to 2 years, getting some real life experience, whether that be volunteering, whether that be going to work right away. Some people are doing research. And then they apply for medical school. They submit a bunch of applications. They have to do these secondary applications. And eventually you get interviewed, you get accepted. Through med school, the first 2 years are your heavy science, minutia, kind of just to prepare you for the USMLE, the United States Medical Licensing Exams. There's 3 parts to those. The first one is very science heavy, detail-oriented heavy, but it's the least clinically relevant. You don't use it as much in your practice. So that's the first 2 years of med school. The third year of med school is your clinical rotations, where you're kind of exploring and doing rotations in different fields like OBGYN, internal medicine, family medicine, pediatrics. After you do that third year, you kind of get a feel for, hey, I might be interested in this field or that field. For me, it was family medicine. And once you make that decision, you designate what specialty you want to do kind of at the tail end of your third year going into your fourth year. And in the fourth year of medical school, you are preparing your application to submit to residency programs for the specialty that you want. And then once you decide, you go on all your interviews to these different places, and you evaluate the hospitals and cities, because this is going to be your new life and your first big job for most people. You submit your match list. The match list is the order of programs in which you hope to get accepted in, right? Everyone obviously hopes to get into their number one program. And then the programs also submit their own match list, right? The applicants that they hope to get in their programs. And then this program kind of tries to match you up, right? So the programs and the applicants get kind of their similar match. So I was lucky to get my number one program, which is University of Arizona College of Medicine in Phoenix. And yeah, that's how I got here. Now I'm almost done.
The thing just with medicine in general that just blows my mind is, getting into medical school is just really the start of all the stress. And it's so stressful just to try to get into medical school. But then you have to go through medical school, which is incredibly intense and grinding, then go through trying to apply to a residency and matching. And then you get into your residency, which is where you've been for the last few years. And how has that process been? How has your experience been during your residency?
Residency has been an absolute grind, to say the least. And you have to remember that my residency started at the onset of the pandemic. So the pandemic started March 2020. My residency started July 2020. There were no vaccines yet. Literally, my first month was during the first massive wave of COVID. And you're just thrown into these hospital systems that are overflowing and overburdened by COVID. and you're expected to perform at the level of an independent physician, there's a huge component of imposter syndrome because you're even scared to put in an order of Tylenol because you're like, oh my God, I'm going to kill someone. And then you get a week under your belt. You're like, okay, I got this. There's a huge learning curve. Every month for my program, the rotations are month long. So every month you are on a new rotation. So the way I explain it to non-medical people, imagine starting a new job the first of every single month. That's what residency is. So like for me, my intern year, I'm family medicine, right? So we say we take care of everyone from womb to tomb, okay? So I deliver babies, I take care of newborns, I do pediatric rotations both in the hospital and the clinic, I do surgery rotations, I am in the hospital for several months at a time, and so I'm doing that every month. It was a lot. It was a long grind. That was your intern year. And then second and third year, I had ICU, which was pretty traumatizing because it was during the third wave of COVID. That was a really hard time for me. And then had some emergency medicine months. And now that kind of I'm on the tail end of my residency, I'm doing more clinic. So kind of my schedule is a little more regular. I'm having more weekends off, things like that.
For you personally, what was it that drew you to medicine and to want to go through just this really difficult process to even get to becoming a doctor? And it's not even guaranteed. Like we were saying, getting into medical school is hard. Matching a residency is very difficult as well. But knowing that uphill battle that you were going to undertake, for you, why did you decide to pursue medicine?
I never wanted to be a doctor. I wanted to be a dentist. And it's one of the reasons I chose the University of Connecticut, actually, because I was a big basketball fan, loved their programs and all that, and they also had one of the best dental schools on the entire East Coast. So I thought by going to the University of Connecticut, it would improve my chances of going to dental school there. My sophomore year of college, my dad had some major health issues that he had a prolonged hospitalization. I think it was about 2-3 months. And, you know, he almost passed away in this time. And I remember sitting at his bedside, and I had no medical knowledge at all, feeling completely hopeless and helpless. And it was at that decision that I made the switch to go into medicine because I wanted to take care of people and give them the help that I wish I could have given my father at the time.
What was it that drew you to dentistry? Why did you want to be a dentist before that whole situation?
So, you know, my dad was an OBGYN. My mom was an ophthalmologist, both trained in Egypt. They came to America. We grew up in Syracuse, New York, to pursue higher education. My mom was doing a PhD program. The plan was to always go back to Egypt. But after time here, schools were better, life was better, so they made the decision to stay. So my dad decided to repeat residency. For foreign medical graduates, in order to practice in this country, even if you were a practicing physician in your respective country, you have to repeat your entire residency in America to practice here again. So my dad started OBGYN residency in upstate New York at 40 years old, and he finished at 44, right? But can you imagine having delivered thousands of babies in your life and then having to start over again, and they treat you like an intern? So it was hard, but he was busy. I didn't see him much. I just remember him being tired all the time, sleeping. He wasn't emotionally present. And I think I was a teenager at that time, and I resented him a little bit for it. Obviously, he was working and trying to provide for his family, but as in my teenage mind, I was like, why isn't my dad coming to the games, things like that. So I told myself I never want to be, I want to be successful, but I never want to be as busy as my dad was. And that was the only example of what a physician is that I had. So I was like, I don't want to be a doctor. So dentistry was kind of that happy medium that I found where I can get the success of being a doctor, but also have a good lifestyle where I can have control of my schedule and be there for my family.
So when you made the switch to decide to pursue medicine, how did you reconcile what your future could look like, given the concerns that you had with your dad being very busy, not being around? How have you kind of pieced all those things together?
So I loved urology specifically. Like surgery. I love the operating room. I loved it. It had a certain like sexiness to it. There was this Da Vinci robot that like, man, you can operate sitting down in this corner and the patient's over there and you're just like doing motions, looking into virtual reality. I thought it was incredible. But the hours were brutal. Like these guys are up, guys and gals, they're up at 4 or 5 in the morning. They're pre-rounding on their patients and then they're getting ready in the operating room at 7. They'd operate sometimes until like 10 p.m. and then they'd wake up at 3. And I was like, whoa, like, I don't think this is what I want. And then family medicine, very quickly on day 2, I was like, oh my gosh, like, this is what I want to do. I had my weekends off. I had no call. I had control over my schedule. And I was kind of doing bread and butter and seeing everything. And I fell in love with it. So I'm lucky in that I chose a specialty that allows me to have a great work-life balance.
Knowing what you know now, with going through residency and dealing with all the stressors that come with it and that come with applying to medical school, applying to residency, knowing what you know now, is it something that you would do again?
No, absolutely not. And I think most residents and, as nearing the end of their training would answer similarly. I think most people would. Ask me 10 years from now and I might have a different answer for you after I've enjoyed the benefits of being an attending physician and attending salary. But right now, knowing what I know and what I've been through, I would have chosen a different career.
What is the most difficult part of residency? Is it just the imposter syndrome, not knowing what you're doing? Is it given a lot of responsibility before you feel like you're comfortable? Is it long hours? What are the components of residency that make it so stressful and so demanding?
We are cheap medical labor. People know this and they abuse that fact. So I'll give you an example. So like on our internal medicine rotations, we're in the hospital. We get there at 6. I'm giving a list of patients that I have to see. It is my responsibility. I pre-round on them, meaning I check their vitals, overnight events, new labs, any procedures, and then I go see them in person. All right, and I have to kind of come up with my plan for each patient of what I want to do and change today. I have to be ready at, usually it's like between 8 to 9 a.m. to present on rounds, right? So there's a hierarchical component. There's a junior on the team, right? There's a senior resident. There's sometimes there's a fellow, and then on top of a fellow, there's attendings. Those are the supervising physicians. And you are essentially placed on a stage, and you have to present to these doctors, right? And your work is offered up for critique. And sometimes the way that critique is given is humiliating. There is something in medicine called pimping, which stands for put in my place, PIMP, where they upper level kind of leaders of the team try to like flex their knowledge, show you how little you know. I would say that happens rarely, but it does happen. I would say most often they do want you to learn, so they're challenging you, right? So then you finish rounds, usually at like 11, sometimes noon. You have a million tasks to do for your patients, the ones that are discharging. You have to write notes on every single one. And then at the same time, you're accepting new admissions the entire afternoon. And then you're also expected to prepare sign out to the night team by 5, 6 p.m., whenever the day is over. These are 12, 13-hour days. Often there's very little time to eat, right? At the same time, these are high acuity patients. If they code, meaning heart stops, their oxygen's tanking, whatever it may be, you got to drop everything and tend to these. And that's one day. And now you do 6 days a week of that. Okay, you get 1 day off a week. And you do that for a month. By week 3 and 4 of those months, you are a zombie. You were just going through the motions. And then say you have 2 of those rotations back to back. Now 3, 4. It drains you physically and emotionally.
Has that always been the case in terms of lack of support, in terms of just being thrown wherever they need you, working these long hours. Has that always been the case in residency?
Yes.
So is it kind of like this hazing mentality where it's like the people who came before you, we've gone through this, so now it's like the younger people have to go through this as well. Is that a component of it?
It's exactly what it is. It's exactly what it is. And it used to be worse. Like, it's hard now. I can't imagine. My dad said when he was a resident, he was working 100 hours a week. We have a program where I train the oral maxillofacial surgeons. They're dentists who do training in like surgery of the mouth. They don't have an hours restriction according to their program. They'll work 120 hours a week. So whereas the average, and this is the trick, right? 80 hours averaged over a week, averaged over the course of a month, right? So if you work 100 hours, 50 hours the next 2 weeks, that averages out to 75. So technically you're not violating hour restrictions.
And I know you've mentioned that you've done 24, 30-hour shifts as well.
Yeah.
How common are those?
So in the entirety of my residency, I will have done 45 24-hour shifts. And I think of those 45, maybe 3 were 30-hour shifts.
When you were first telling me this as you were going through it, what boggles my mind is, how is this legal? You know, if you are literally have people's lives in your hands, and we're going to sleep deprive you, put you under stressful conditions, and then expect you to operate at a very high level in the 27th, 28th, 29th continuous hour of a shift. How is that? I don't understand how that's legal. To me, that seems like such a disservice and potentially dangerous thing to do, to put people under the supervision of people who are sleep deprived. No matter how smart or intelligent or a doctor someone may be, when you're that deprived of sleep, because I know on those overnight shifts, I don't imagine you get much sleep at all.
No, I'm lucky to get 2 hours on those shifts. The justification for those shifts is continuity of care. Every time a doctor goes off and another one comes on, you have to hand off the patient, which means you have to present them and relay all the information. The more handoffs you have between physician to physician, the higher the likelihood of a mistake happening or something being missed. So by keeping a physician on for 24 hours who knows these patients intimately, you decrease that risk because you're decreasing the number of handoffs.
Is the average person in the hospital stay for less than 24 hours?
No.
Is it going to be a handoff anyway?
Yes.
So how?
It doesn't make sense. It doesn't make sense. So you're on these shifts, right? You're covering the team, their list. So any acute events for this list that you're handed, you're in charge of. You're also in charge of new admissions to your team. And then the next day is like, they call it a post-call day. So if I work 7 a.m. to 7 a.m. the next day, I'm off that day. That is not a day off, okay? That you are sleeping till 12, 1, 2. You wake up, you feel drunk, and you're just like all day, and then your sleep is off, and you feel like crap for the next 3 days. And you like takes time to recover from these shifts.
How soon do you have to go back in?
With my program, when we're on our hospital service, our own team, and I'm the senior, sometimes I'll do every other day.
24-hour shift every other day?
So I'll do a 24-hour shift on a Friday and a 24-hour shift on a Sunday.
So that day in between is just...
That's my day off. Yeah. My day off. And that's a post-call day. Because I got off on Saturday, 7 in the morning.
As you describe this, and I've heard you talk about this, of course, you know, the burning question for me at a very high level is, does it really need to be this way? Do we need to treat the residents this way and usher people into the medical field under such conditions? Like, is this necessary to do it this way?
I don't think it's necessary. I think, and I hate saying this, I hate that I'm going to say this, but I think it works.
Why does it work? In what way or what purpose does it work?
Because you are making life and death decisions about patients' lives in some situations, right? You need to be challenged. You need to be made to feel uncomfortable. And with the amount of hours and repetition we do, you are definitely going to feel that. when I'm on those 24 hours, I'm by myself. Yes, I have a supervising doc on the line if I need help, but for the most part, I try not to wake them unless I absolutely have to. COVID ICU was traumatizing, but unfortunately, by going through that, I now feel confident. When a patient of mine is decompensating, I don't panic anymore because I went through hell. I went to war. So, does it work? Do I now feel like I'm graduating residency, confident and ready to be an independent doctor? Absolutely. I feel, and all my colleagues I know feel the same way. We were very well trained. And I think a part of that reason is because it was hard. And doctors or residents who tell you residency was easy, I don't know what program they went to, and I would be wary of those people as doctors because, frankly, the best doctors are the ones who've been through a lot and came out on the other side. And the thing is, though, and the thing that frustrates me and a lot of other residents is that attendings will come out on the other side and then very quickly forget what it was like to be a resident. And then they perpetuate these toxic hierarchical structures of the residency systems. It's our job as residents who have been through this, now moving forward into attendinghood, being cognizant of what the residents are going through and trying to make the workplace healthy and cohesive and help decrease the stress as much as possible.
What keeps ringing in my head is the analogy that you used of war, having gone through war, which is obviously such a powerful analogy. When you were going through it, those being in the trenches, to continue with the analogy, how did you get through it? How did you manage being sleep deprived, being burnt out, being stressed? And I ask specifically in your case because, I think a lot of people experience burnout at some point in their career, feeling overworked, undervalued, not being paid enough, whatever the situation might be. And for a lot of people, myself included, the solution is get a new job, change companies, maybe switch careers, maybe take some time off in between jobs or take a long extended vacation. These past 3 years, you obviously didn't have the option to do that. I mean, I guess technically you theoretically could leave, but you're not going to. You've invested so much time and money that of course you're not going to. So knowing that you have to stay and you're going to stay in this career and you have no agency in reclaiming some of your time or taking extended time off or switching companies per se, how did you get through those really difficult periods?
It was really hard, man. It was really hard. Depending on the rotation, some were really hard. The hours were hard. I was sleep deprived. I had a new girlfriend at the time. I could barely see her. I had sometimes like a negligible social life. And I think I never knew how, and what I would tell new up and coming doctors and medical students is I never realized how isolating it is being a resident and a medical student, right? You think you go to med school, you make all these friendships. You do. But at the same time, you're in the library studying 5 hours. And when finals and USMLEs come up, you're sometimes studying 10, 12 hours a day by yourself. It's very isolating. And then you get to residency. You're surrounded by all these wonderful residents. And you do develop this camaraderie. But at the end of the day, it's you and your work and your notes. And you're lucky if, you just get to bed on time and shower and take care of yourself. And it's hard. I would take it one day at a time. And I knew that this isn't forever. And you can do anything for a month. And that was literally the mentality I had to have to survive.
So it's a survival mentality.
It's a survival mentality. And some people do better than others. Some people break and need to take time off during residency. Some people have a hard time coping with being away from their children, for those residents who have kids, And it's interesting, going back to my father real quick, having gone through residency now, I now completely understand why he was absent in my teenage years.
I want to switch gears a little bit, talk a little bit more philosophical about the idea of work and how you define work for yourself. What is it that brings you the most meaning in your work? And was that a factor for you in pursuing not only medicine, but your specific specialty within medicine as well.
My favorite part of my job is clinic. That's why I chose what I do. I love what I do.
What do you mean by clinic?
Clinic is, or outpatient is primary care. If you have a cough or a cold and you're not getting better, you schedule with your primary care doctor to see you and be evaluated. That is what I am, okay? I love when patients come in. I sit down, tell me what's going on, and we talk face to face, just like this. And, okay, while they're talking, I'm kind of gathering my thoughts, what might be going on. I do my exam, and then I have a conversation with them, and I present the facts. And I love this because this is I think one of the flaws of our medical system is we diagnose and just throw medicine at it and be like, oh, see you at your follow-up visit. And I think, and through my curiosity, I've asked patients, I see you have high blood pressure. Do you know, by chance, do you know what high blood pressure is? Do you know what hypertension is? A lot of them can't answer. It's just something they've been diagnosed with, and they take a pill. They don't even know how their medications work. So I try, to my detriment, because remember, I have to do notes, I have to put billing, I have to put orders, things like that. I try to spend a little extra minute or two to explain to the patient and educate them about their condition, about their disease, about the medication, how the medication works. Because once you help them understand the pathophysiology of what's going on with their bodies and how this medicine is working to affect that physiology, they now, when they have that aha moment, which gives them agency over their own health. It is one of my favorite moments as a doctor, is those aha moments, and patients really get motivated to take things seriously and take charge of their health.
So for you, it seems like what's at the core of what you really love about what you do is the education and empowering people to take ownership over their own health. How are you thinking about making that central in your career going forward when you start practicing as a full-time doctor?
Great question. So before I was a doctor, I was an amateur barber. Started in college, fell in love with it, was cutting out of my bathroom, carried on to cutting for my family. I cut for med students and patients when I was in Salt Lake City. So it's something that I've always deeply, deeply loved. But when I was in Salt Lake, I went to a barbershop in the Rose Park neighborhood, which is predominantly black and brown neighborhood in Salt Lake. And when people found out I was in med school, I had a line of people that were asking me questions and like, hey, my 8-year-old child has asthma. This is what I'm doing for them. But he's still uncontrolled. How can I help him? And then the barbers found out I was a doctor, and they were telling people like, yo, ask him, he's a doc. And so I realized there was a need there. And I was like, there's something here, right? Because we're targeting a predominantly group of men, young men, who think they're invincible, majority of whom are uninsured, who never go to the doctor. First time they present to the healthcare system is when they're 40, 50 years old. They've had a heart attack or stroke from something that could have been completely preventable if it was just detected when they were younger. So this is what kind of kickstarted my vision of potentially creating a barbershop health clinic of sorts.
Ever since you've told me about this idea years ago, I've loved it because there's obviously a need for more access to healthcare in black and brown communities. And rather than just going out and trying to knock on people's doors or trying to open a clinic and get people to come to the clinic, what you're aspiring to do is meeting people where they already are. And I think that's a valuable framework to think about finding customers for any potential businesses. Don't try to, get people to contort their behavior. Meet them where they are. Provide the solution that they need in a way that resonates with them, and here you're talking to them in an environment they're very comfortable in the barbershop, and giving them services that they want or maybe they're looking for but don't necessarily know how to access it. So I think your idea is hitting a lot of those key points that any successful business would want to aspire to.
I think the one thing I've learned is you can't sit on your butt and just wait for people to show up in your clinic, especially those who are in the most need. You have to meet the community where they are at, right? this study, especially looking at hypertension screening in black barbershops, has been done and it has been reproduced in places such as Denver, Dallas, and it has a number needed to treat of 2, meaning for every 2 people that you treat, one of them is going to be effective. That is an incredible number. So basically, they're going into barbershops, they're identifying males with high blood pressure. They have a pharmacist who's in the clinic and who's coordinating distribution of hypertension meds. And out of every 2 that are treated, 1 is able to get normal blood pressure. That is an incredible number. Ideally, we want 100%, but there's nothing that is 100% effective all the time.
So this concept has been tested before.
And proven.
Yes. And before we started recording, you were mentioning that you're actually going to get some personal experience with testing out this idea in your own locale as well in Phoenix. Is that right?
Correct. So I made my own little project month, and basically I will be posting up in a predominantly black barbershop in Phoenix about 2 days a week, and I will do blood pressure screening there, in addition to diabetes screening as well. And frankly, if anyone wants to talk about any health issue or concern, I'll be there, right? I can't legally prescribe them medications because I'm still in my training, but when I'm an attending physician, I can absolutely write medications and treat on the spot. And I can even conduct follow-up visits in the barbershop. And I can make it a regular part of my, volunteering during my attendinghood life. And then, hopefully when I become more established, get my loans paid off a little bit, I can now start to transition and figure out a way to make this my career.
What would it mean for you, say fast forward 10 years from now, this vision of combining your personal interest in cutting hair and helping people in underserved communities with your professional training, medicine? What would it mean to successfully hit the mark in the center of that Venn diagram? How do you think it would feel to be able to find success in that middle lane of both of those 2 things?
That's a great question. I think first and foremost, my number 1 priority is giving excellent care to communities in need. That is my number 1 priority. The other thing is I also have to find a way to make this economically sustainable, because if it is free screening, we'd have to just get grant funding and, it would have to be on a volunteer basis. I still haven't figured out the business model side of it to make it sustainable while also having a positive community impact. But my vision is creating a combined space where people are coming for their haircuts. They're always going to come. They're not always going to go to the doctors. So imagine you have a barbershop, right? And then on another side, you have a clinic. Say you have a social worker there as well. Say you have a pharmacy there, right? Say you have an imaging center there. So it is literally a one-stop shop for quick healthcare needs that everyone can get addressed when they go to their haircut. I believe deep in my soul that this concept will catch fire and grow in popularity, and I see it franchising and going to different cities who have this need, and I know for a fact every major city in this country has this need.
Yeah, I think the mechanics of the business model is TBD. I think that when you get to that point where you're actually going to launch this, you could sit down and figure it out. Obviously, there needs to be a need for this and a market for this, and I think just anecdotally, and even like you said, the proof of concept that's been shown, there is a need for this. So I think, yeah, you have to figure out the mechanics, but I think there really is something there. Last thing I want to touch on, obviously because it's a hot topic nowadays, and knowing a bit about the nature of your work, is the role of AI in the medical field. Aside from, before even getting into using AI in practicing medicine, right? Because maybe that's down the line a little bit. You could fill me in on that. I'm just curious today, where we are today, with ChatGPT, Google Bard, Bing has their AI software as well that's open source, free to the public to use. Have you thought about using any of these AI sources to help you with some of the tedious parts of your job, like sending emails, taking notes, so you could get back some of your time and then focus more on the meat of your work, treating people, interacting with patients? Have you thought about or have you experimented with doing anything like that?
So it's funny you asked this. I was on hospital wards maybe a couple months ago, and Chat GPT had just come out, and so I was like, oh, I want to see how effective it is. So I asked it like a simple question, like what antibiotics do I prescribe if this, and this, and it was spot on, man. It like gave pretty accurate information and listed resources and supporting reasons for why it chose that antibiotic, and I was like, oh my God, this is scary. But the database that we rely on is Dynamed, UpToDate. I don't know where ChatGPT is getting its information from. If the UpToDate, if our databases are a part of their database, and then until that happens, where there's a ChatGPT specifically for medicine, I would not use AI to make medical decisions. I think UpToDate and all that supplements what we already know in our training and what we're taught clinically. Where I do think there is a need is the kind of bureaucracy side of it, the emails, the documentation, the coding, the billing. I would love for there to be some sort of conversation capture technology where I'm talking with my patient and the AI is literally typing my note and filling in the details and like showing me areas like what I need to do and whatnot. I think that would be a really cool addition to the healthcare field for sure. And it could be like, for example, like, hey AI, like tell me what vaccinations this patient is due for. Like AI, can you, if they, for example, mention something and you're not seeing it in their documentation, like you can ask the AI to like, hey, can you search the records and see if they've ever had a colonoscopy? Little things like that, I can see it being very helpful, but I don't think we're there yet. But I hope the technology gets there.
A lot of people obviously have anxiety about AI coming for their jobs, making their tasks obsolete. Do you have any of that anxiety in the medical field, or is there a sentiment about that in the medical field about even maybe if it's not doctors, maybe it's PAs or nurses or something like that? Is there a general sentiment, if you have any knowledge of this, that people are afraid of the fact that AI might encroach on their job and their usefulness as a human worker?
I don't have an answer to that. The area I can see it being potentially a problem is scheduling of our patient appointments. So already with humans, they do a good job, but there are still mistakes being made. So for a new patient, I'm allotted 40 minutes of time. Sometimes with new employees who are staffing, they'll make mistakes and accidentally schedule it for a 20-minute.
What about for you in your job as a family medicine doctor? Do you have any trepidations, even longer term, 10, 20, 30 years? Do you think you're insulated from potential existential risks from AI in that regard?
I truly feel AI cannot replace me. And what I know, it has not gone through residency training. It has not learned the clinical science. It just knows what it knows from a book. But it has not seen and experienced and done what we've done. So I personally feel we can't be replaced by AI. That's how valuable I think our knowledge base is.
I think that fortunately puts you in the minority of a lot of college-educated workers who are anxious about the threats posed by AI and potential existential threats for their job as well. So very interesting that you have a very optimistic take on seeing AI as a potential enhancer in your role rather than a threat to your role. So that's pretty awesome. I think that's about all I wanted to cover today. So I wanted to take a minute again to thank you for joining me here. I appreciate hearing your thoughts on your experience, and I look forward to continuing seeing your journey in the medical field and seeing your barbershop, doctor clinic come to life.
Give it some time, but I'll bring it to life. Thanks for having me, man.
Thanks, Ali.
Appreciate it.
If you enjoyed this conversation, please like this video and subscribe to the channel. That's the best way you can support.